If uterine cancer is on the rise, and it is, it's the #1 cancer on the rise.
Interesting.
It's 1 in 32 women, and it will be 1 in 17 by 2050.
Wow.
Yes, it will be the second most common cancer among women by 2050. It's already more common than colon cancer. And right now, we are in a place where everybody is getting hormones. And like you said, many are not getting exams and they're not getting ultrasounds. I think it's reasonable to sound maybe not an alarm, but a flag.
Right.
To say, hey, if you still have your uterus, you need to make sure you had a very clear conversation about what doses am I on, what is going to protect the endometrium or that uterus, and how are we going to monitor it to make sure that there are no issues.
Dr. Kemi Dahl is a physician, surgeon, researcher, and advocate and coach working at the intersection of health justice, reproductive equity, and personal empowerment.
Right now, in 2026, Black women have a 2 times chance higher of dying after uterine cancer diagnosis. The way that our diagnostic system works is that when you come in, we're supposed to do an ultrasound, and that ultrasound is supposed to tell us whether there's any risk that you might have cancer.
And what are you looking for historically on that ultrasound?
We're looking for the thickness of the uterine lining.
Okay.
So we call it the endometrial stripe. If it's under 4 millimeters, you're supposed to have a 0% chance of having uterine cancer. Except all of that research was not done on women of color, especially not done on Black women.
Wow. Her groundbreaking research on racial disparities in endometrial cancer has been funded by the NIH, the PCORI, and the Robert Wood Johnson Foundation, and has been featured in the New York Times, NPR, BET, and Good Morning America. Please join me in welcoming Dr. Kemi Dahl to the show. Hi, everyone. It's Dr. Taz. Before we get into today's episode, I just want to pause and say thank you. Your messages, your shares, your stories are the reason we make Whole Plus. Every conversation here is about connecting the science, the intuition, and everyday life together so you can feel more like yourself again. If you haven't already, hit that subscribe or follow button. It helps us reach more people who need this. All right, let's begin. Dr. Kemi, I am so glad you're here, and I'm going to tell you why. I have been in practice for over 20 years in probably this integrative space, and I have sat with so many women, especially women of color, that are not getting sort of the GYN help that they need. They are suffering from all kinds of different symptoms and conditions that I don't see in our Caucasian or even South Asian counterparts. And when I go to the research, right, when I start to dig away and I'm like, okay, how can I do something? What can we do here? There's really not a lot there. Yep. You have dedicated your career and your life to helping Black women and trying to understand what's going on with them, understanding what's going on with the womb, right? How did you get into this space? What is motivating you and inspiring you to really start to turn the page on this topic?
Thank you so much. Thank you for having me. I'm
Yeah,
really
thrilled
happy
to have
be
you.
here. Really happy to be here. There's so many things that motivated me, but I have to be honest to say that probably in an unconscious way, I think my grandmother's story and her life motivated me, because I found out fairly late, actually into my adulthood, that she had died in childbirth.
Such a common story,
Such
right?
a common
for
story.
Previous generations of women.
Exactly. And then my mother almost died giving birth.
Which was not that long ago.
And then here I am, and I survived. And so I just say that because I think that in a way, this is exactly the work I was always supposed to be doing. And I gravitated naturally to it. In medical school, I loved OBGYN. I loved everything about women's health care. I was totally zeroed in on it. And then when I went to residency, I really just got fascinated with gynecologic cancers, mostly because I was just amazed that the uterus could do so many different things, and that this organ is incredible. I mean, it can grow life, it can grow a cancer, it bleeds every month. I was scientifically fascinated with it. And then more than that, I found that unlike any other organ, the meaning that we make out of what's going on with our womb, what's going on with the uterus, the symptoms that we have, it just impacts so many parts of our lives that it meant a lot to me to serve women in that way. And so I just feel like so aligned with this work.
There's so much like written in the energetic and spiritual world about the significance of a woman's womb and what that means. You know, I have a background in Chinese medicine as well as our conventional training. And they talk a lot about that as being the life force
Mhm.
of a woman, like
Mhm.
that entire pelvic floor region, the
Mhm.
womb, all of it.
Mhm.
And when it's compromised or when it is not maybe working at the capacity that it was meant to work at, that
Mhm.
was a very important determinant of not just womb health, but overall health in
Exactly.
general,
Exactly.
But I want to go back to your grandmother. So
Sure.
what's the year? Tell us the timeline.
Oh gosh, I would have to do the math.
Roughly. You don't have to be
Roughly, we're talking 1950s.
your grandmother,
My
1950s,
grandmother.
and then your mom.
My mom, 1980s.
Okay. So we're talking mid 1900s,
Yeah.
now going into the later, 1900s. Now we are in the 2000s.
Yeah.
Has anything changed?
Very little.
That is what's so disappointing.
Exactly.
So what happened to your grandmother?
So nobody knows what, I mean, at that time, the story was simply that she bled too much,
Mhm.
you know? Now I think about the fact that fibroids run in my family, endometriosis runs in my family. Um, I had issues with heavy bleeding and anemia. These things all add up. And I think what we see often is that we see them come to a head when a woman is trying to give birth, right? Everything comes together and there's a lot of risk there. But my work is about recognizing that that's not the only time that
Right.
we're at risk.
Right.
And I want the conversation about womb health to get beyond just the moment of pregnancy and giving birth, to recognize that we spend most of our lives not pregnant.
Mhm.
And every single day, a lot of us are taught, unfortunately, to suffer and to just normalize the symptoms that we have from these various gynecologic conditions, to the point that we are vulnerable enough, honestly, for it to be a life or death thing. And so that's kind of why I'm here. My work is about humanizing that aspect of our life every day, taking it out of silence, and then asking, what can we learn from what's going on and how can we heal?
Why do you think there's such a gap when it comes to understanding that what Chinese medicine, Ayurvedic medicine, all these older systems of
Mhm.
African medicine, they all already understood this,
Mhm.
right? They
Mhm.
already understood in their language
Mhm.
that the womb was a symbol of overall health for a
Mhm.
woman, right?
Mhm.
It wasn't the separate entity that lived over here and you just
Mhm.
used it to get pregnant and
Mhm.
then you took it out when you no longer needed to have babies anymore,
Mhm.
right? So that was
Mhm.
sort of the standard of care.
Yeah.
Why did we miss the mark on that
Mhm.
where we're not thinking about the womb, not to use the word, flippantly, but we're not thinking about the womb in a holistic way?
I mean, I think the short answer is misogyny. I mean, I think
The
the
patriarchy.
patriarchy is usually the answer. I
Yeah.
mean, if you think about the Western medicine framework and our
Mhm.
biomedical, like, industrial complex, which I am a part of. I believe in science. I love science,
Same. Mhm.
right? But when you recognize that, like, we don't have an institute for women's health at the
Right.
National Institute of Health. Like, we have an institute for the heart, the blood, the kidneys, everything, but we don't have anything for gynecologic
Hmm.
health. So that alone, even though half the population has these organs, and these are very common conditions we're talking about, not rare.
Right.
So I think part of that perspective that we have, that this is just for pregnancy and then we'll take it out, is that we have devalued
Yeah.
the importance of the womb and the uterus from a biology standpoint, from a health standpoint, and from a research standpoint. And we are just beginning to turn the tide on that, but we have decades of catch up to
To
do.
do,
Yeah.
yeah. Well, let's first talk about the womb, and then I do want to get into some of the issues around, Black women and what's happening in
Mhm.
particular in that community. So, the womb in general, what are
Yeah.
we missing when we think about overall health in the womb?
Yeah. So first is that your womb health lasts a lifetime, and so I think even that recognition that, before puberty there's not much going on, but those organs are growing. And then when we get into puberty and girls have their first period, most of us were just taught how to keep it quiet. I mean, a successful period was one where nobody knew that you were bleeding, right? You get taught to manage the blood, but you don't really get taught what are these organs and what are they doing. So I always start with reminding people that, the uterus is just one part of the reproductive health system. You have fallopian tubes, ovaries, etc., but it's a very critical part. And the way that I think about menstruation is, obviously, we bleed every month. There's cramping involved. It's not great sometimes, but from a medical standpoint, it's something really incredible.
Hmm.
And I think this is what you're talking about the other systems understanding something more deep than we have. From a biology standpoint, it's the only place in the body where you have a wound with a scarless repair.
Fascinating.
Yes, and talk about the
That's so true. I
metaphor
never thought
already.
about
Yes,
that.
so
Yeah.
every month, right, this wound forms on the surface, on the inner lining of the uterus. You have the shedding, you have everything that's supposed to happen, and then there is this beautiful repair process with no scarring.
Mm.
And so even giving women that imagery and that understanding starts to shift how you think about what's happening. And then it can help us understand why it's starting to go wrong.
Mm.
What's wrong with the shedding process or what's wrong with the repair, and how that's leading to potentially too heavy cycles or too much pain. And then we can start to get into the biology of it and what works and what doesn't. So that's how I would start with saying like what's going on with the womb. There's so much more,
Scarless
but
recovery. I love that. That's something that
yes.
all of us should remember. We're capable of scarless
Right.
recovery. Who
How's that for
knew?
meaning?
Yeah.
Yeah, it's like, yeah, I think about that a lot actually. Like, how can we think about that in the rest of our lives
Right.
too, right?
Right.
Like, we are all wounded in some ways. And I think we're all looking for a scarless repair, you know?
I love that.
Yeah.
What has your work, and I know you're doing a lot of research around the womb,
Mhm.
what has your work sort of focused on when you're
Mhm.
doing research,
Mhm.
and how does that translate clinically to a certain
Yeah.
extent?
Yeah, so two things. So I tend to research actually how health systems and how our communities and our belief systems interact with the health system to
Mm.
create, unfortunately, a lot of delays in care. And then I also do a lot of work on how our technologies like ultrasound and
Yeah.
our diagnostic systems do or don't work,
Ooh, that's
especially
gonna
for
be
women of
interesting.
color. Yes. And so one of the things I think we can start with is this idea of uterine cancer and diagnosis. And
Okay.
so I'm a gynecologic oncologist, so
Mhm.
I spent most of my time taking care of women with gynecologic cancers. The most common of which is uterine cancer, which
Mhm.
most people don't realize. They think it's cervical, but it's
Right.
not.
Right.
Um, Uterine cancer is diagnosed through post-menopausal bleeding. So a woman is done with menopause, and then she starts to have a few drops of blood again. And we have an assumption in medicine that if that happens, a woman would run to the doctor.
Mhm.
That assumption does not take into account a lot of women have negative experiences when they go to the gynecologist.
Right.
A lot of women don't even have a gynecologist anymore after they've had a baby. And we are taught again to just manage things that
Mm.
go on down there. So
Mhm.
if you have a little bit of bleeding and you're not cramping, you're not in pain, you might just keep moving with your life.
Right.
So the way that our diagnostic system works is that when you come in, we're supposed to do an ultrasound, and that ultrasound is supposed to tell us whether there's any risk that you might have cancer.
And what are you looking for historically on that ultrasound?
We're looking for the thickness of
Mhm.
the uterine lining.
Okay.
So we call it the endometrial stripe, the thickness of that. If it's under 4 millimeters, you're supposed to have a 0% chance of having uterine cancer. Except all of that research was not done on women of color,
Mm.
especially not done on Black women.
Wow.
Exactly. So you know what
Wait,
changed?
who is the sample size then? Who are they looking
It
at?
was done in Scandinavia
Okay.
primarily, so mostly Caucasian women, and there
Okay.
was one study from Hong Kong.
Wow.
Think about how many people that leaves out.
Right.
They also excluded women with fibroids.
Why?
Okay.
Why would you do that?
70% of Black women
They're
have
the
fibroids.
highest
80%.
risk.
Yes. So, and it was really oriented time towards a certain kind of uterine cancer, not to get into the weeds,
Right.
that is less common in women of color.
Right.
So what happened was over time, over and over again, even when coming for care, Black women would get these ultrasounds and then get reassured
Mm.
that everything's fine. You don't have cancer. And then take years to come back after now I'm really bleeding. Now I'm having a lot of cramping. They'd be diagnosed at later stages and they would die.
Mm.
And so this is why right now in 2026, Black women have a 2 times chance higher of dying after uterine cancer diagnosis. And this is the #1 climbing cancer in this country.
Wow.
It is more common than colon cancer among women. So I'm not trying to scare people, but I'm giving you a picture of what happens when we forget womb health. Most people don't know that uterine cancer is more common than colon cancer. Why is that?
I don't know, but I will tell you this just from practice.
Yeah, go ahead.
This has bothered me, and you probably have a better answer to it. So we have this checklist, right, of preventive screenings. Like we're
Yes.
set up as like whole family, so we
Yes.
do whole family care. So when women come in, and I'm going through the list of preventive screenings to make sure they've had everything like colonoscopy check, mammogram
Yes.
check, all that other stuff. There's no standard of care that I'm aware of,
Yep.
unless I'm behind, of screening the uterus.
Correct.
So what I'm having women do, which you can probably correct me on if it's not the right tool, what I'm having women do is that minimum every 3 years, I don't care if you're 40, 50, 60, 70, I'm sending them in for a pelvic ultrasound if they still have their uterus. That's just sort of an arbitrary thing I brought up on, I kind of made up on my own, just watching women and watching what we were dealing with.
Yeah.
What would you say to that?
I would say I don't think it's crazy. So so this is what I would say, a few things.
Okay.
One is that a lot of women go undiagnosed for a long time with conditions because they think everything's normal.
Right.
They have learned a standard of normal that is wrong, right? So they don't realize that their pain or cramping is to the extent to which this should be evaluated, or they don't realize you are bleeding so much you might be anemic. So I think it is actually incumbent upon us doctors to take a further step instead of waiting for somebody to say, hey, something's wrong. The second thing is that, my very peer-reviewed, very scientific, very traditional colleagues might get upset with me about this, and I think that's okay.
They're always mad at me. It's all right.
Okay, I think we have
You're
to
in
figure
safe
out,
space.
we have to figure out how to bridge the gap. Is
Yeah.
what I'm saying.
Yeah.
And we are in a time where people want information about their bodies. People are really, really motivated right now to understand like what's going on. They want information, right? And we have to get away a little bit from this idea of, well, when we studied looking at ultrasounds in 50-year-old women and we could not detect that we found anything, that's one thing to say. Maybe it doesn't decrease uterine cancer rates, but that's not the same thing as somebody having a better understanding of what's going on.
Right.
Maybe they understand, that you have a polyp. And it's probably okay, but if you ever have this symptom, then we should do something about it. Or maybe they learn you have a 2-centimeter fibroid and it's asymptomatic. That's great, right? However, if it's that way now, you might decide to start taking vitamin D. You might decide to do things that are helpful to halt fibroid growth before it gets symptomatic.
Right.
That is reasonable. I think that we need to be in a place where we're more in partnership with patients. And sometimes that means offering them information, even if we think this isn't telling me anything. So that's what I would say to you. I think every 3 years is totally reasonable. I mean, that doesn't sound crazy to me at all.
I want to pause here because I see this pattern all the time. People are doing the research, they're listening to the podcast, they're trying to take better care of themselves, and they still feel so stuck, especially when it comes to their health, their hormones, their stress, and even taking care of their families. That's why I created The Circle. The Circle is my private membership where we go deeper into these topics with real guidance, demos, live sessions, and a supportive community. If you want to try it, there's a 1-month trial available right now. You can learn more at wholeplus.co/circle. That's HOLPLUS.co/circle, or just click the link in the description below and use the code YouTube. Now let's continue the conversation. Well, I'm glad. And then the other thing that sort of I've noticed, and I'm sure you have too, is that with this explosion around HRT, right? Like
Yes,
hormones
okay,
for
let's
everybody.
talk about that too.
Like,
Another reason to do ultrasounds.
why
Yes.
would you do hormones for everybody at some of these doses, right, when you have a thickened endometrial lining to begin with?
Okay.
Or fibroids.
Dr. Taz, thank you for bringing this up.
No, I'm just saying.
is
I mean,
so-
like,
no, this is
right now,
so
it's like,
important.
I got my patch. I'm making fun of this. I do not need, I'm all
No,
about
no, we are
hormones.
all- okay.
I am all about hormones. I'm on
100%.
hormones.
Listen,
I
hormones
love
for
them.
everybody.
Hormones
Yes.
for everybody.
However,
Not where you like type in something and then get your prescription in the mail without a proper screening.
I'm very concerned about this. I just want to say, again, as a gynecologic oncologist, and I want to be really clear about this because I agree with you. I am not anti-HRT. I think people should be on hormones. I do not think women should suffer through menopause. And we are missing the conversation about the womb and menopause.
Yes.
I am not hearing people talk about the fact that uterine
100%.
cancer is absolutely a risk when you're on HRT, if you're on estrogen without progesterone.
Right.
Yet women are being given estrogen without progesterone who still have a uterus. I'm talking to women who say, well, I was given both, but the progesterone gave me some side effects, so I dropped that one. They have no idea that it's there to prevent cancer.
Right.
And I don't think I'm being fear-mongering when I say if uterine cancer is on the rise, and it is, it's the #1 cancer on the rise.
Interesting.
It's 1 in 32 women, and it will be 1 in 17 by 2050.
Wow.
Yes, it will be the second most common cancer among women by 2050. It's already more common than colon cancer. And right now, we are in a place where everybody is getting hormones. And like you said, many are not getting exams and they're not getting ultrasounds. I think it's reasonable to sound maybe not an alarm, but a flag
Right.
to say, hey, if you still have your uterus, you need to make sure you had a very clear conversation about what doses am I on, what is going to protect the endometrium or that uterus, and how are we going to monitor it to make sure that there are no issues. Because unfortunately, I have heard stories. My gynecology colleagues are telling me,
Mm-hmm.
listen, women are coming in with estrogen levels at 100,
Right.
no
Right.
progesterone, and a thickened stripe at 62. And
Yeah.
I'm like, oh my
And
gosh,
I'm seeing that in
you're
practice too,
seeing it
by the
too.
way. I'm
So
seeing the
yeah,
exact
thank
same
you.
thing.
So
Yeah.
I just, again, it's about the balance of things and about bringing the womb back into the conversation.
Well, let's go back to the womb
Yes.
for a second.
Yeah.
I have so many questions, but
Okay.
going back to the womb, you talk about there's a crisis
Yeah.
when it comes to the womb of Black women,
Yeah.
right? I think you have a term for it as well. But in general, when
Mhm.
we look at the stats on the health of Black women across the board, right?
Yeah.
They have the highest sort of morbidity and mortality when it comes to childbirth.
Yeah.
They're very behind when it comes to many of the other markers around women's health in general.
Yeah.
We know in the research and we know clinically that they're suffering from
Yeah.
fibroids and, a lot of issues with endometriosis,
Yes.
ovarian cyst,
Yes.
a lot of these different conditions. And the answers for most of them that, at least again, I'm aware of, is take it out. Myomectomies to take the fibroids out,
Yeah.
hysterectomies to take the uterus out.
Yeah.
So let's go back to what's happening with the womb of Black women
Yeah.
today.
Yeah.
Why are they having such an issue
Yeah.
in comparison
To others.
to the others?
Let's take fibroids.
Okay.
Okay. So fibroids grow because of actually a single cell. A single cell will be mutated. It's a muscle cell in the uterus. There's a number of different kinds of mutations that can happen. And once that muscle stem cell changes, it will start to grow basically out of proportion and create a fibroid.
Okay.
That's what happens. Fibroids in most women start in their 30s and grow from there. In Black women, fibroids start as early as the late teens and early 20s
Okay.
years. So it's actually true that like 80% of women will have fibroids at some point in their life because, again, these little mutations happen, they grow, and then they go away. So half of fibroids will grow and disappear, grow and disappear. This is why I tell people don't freak out if you
Right.
see one. For Black women, they start earlier.
Why?
They grow. We don't know.
Okay.
We don't know why they start earlier.
Okay.
But if you think about the fact that there are basically random mutations that are happening, there's probably an element of environmental influence there,
Mhm.
as well as a predisposition, because we know fibroids tend to run in families as well.
Mhm.
And so when that happens, you have Black women who now have larger fibroids that started earlier, that are now more symptomatic earlier, except they're not seen as vulnerable. They're not going to the doctor, or when they're going to the doctor, they're getting dismissed. So paradoxically, they're getting treatment later. So
Mhm.
by the time somebody is really taking them seriously to say, oh my gosh, there's a problem here, let's do something about it, there's only the option of hysterectomy, or there's only the option of myomectomy. So I want the awareness to recognize that if this is a problem that's happening in young Black women, we see these asymptomatic, they start off with no symptoms, fibroids in Black women in their early 20s. That's when we should be paying attention. That's when we should be starting the therapies that we know can halt fibroid growth,
Right.
and give them more options instead of waiting until things are symptomatic. So that's like I think a really good example. There are a lot of hypotheses about like what's going on, and I'm gonna do a little bit of like science plus woo woo.
Okay. I love it.
Right?
That's me.
That right? We love
That's my
this.
jam.
That's
right?
my jam. Okay, so for example, there are things that we know that are associated with fibroid growth. One of the things that's associated with fibroid growth and women with more fibroids is chronic stress.
Right.
We also understand that Black women experience a different kind of chronic stress in this country because of the intersection of racism and sexism that we deal with, and that happens from an early age.
Right.
Another thing that's associated with fibroids is something called anger squelching. Have you heard about this?
No, but I'm gonna go on a rabbit hole with you in just a minute, so I don't want to interrupt
Okay.
you because
So,
you're gonna die in a second. But keep going.
okay. So anger squelching, it's come from the psychology literature. When instead of releasing your anger, instead of expressing your anger, you suppress it.
Yep.
Right?
Yep.
Think about the angry Black woman stereotype.
Yep.
You're not allowed to be angry. There's lots of consequences if people feel like you're doing too much. Women with high levels of anger squelching have more fibroids. associated with more fibroids and fibroid growth. So what we don't know yet, because I want to be really clear, I can't trace to you right now yet the mechanism of like this emotion, this neurotransmitter, this molecule, this fibroid, but you start to see those patterns. And then it's not shocking to me that 80% of Black women have fibroids and that they're bigger and that they're more intense. So I like to open up the conversation to just say, listen, there's a lot of science going on in how to treat these. There's a lot going on in figuring out how to stop growth. And I love that work and that we can get into that. And we have to acknowledge that the data shows that this is not just a unilateral, like scientific condition that is not connected to our environment.
Okay.
Okay.
Are you ready?
Okay, I'm ready.
All right. Anger squelching. We got to
Yes.
talk about anger
Okay,
squelching.
let's talk
All
about
right,
it.
Because, get ready,
Okay.
in Chinese medicine,
Okay.
the liver
Yes.
holds anger and is the seat of anger. So people with repressed anger or anger that's developed even intergenerationally,
Yes.
that's held, according to Chinese medicine, which is a more
Yes.
energetic system of
Yes.
medicine, right?
Sure.
That's held in the liver.
Yes.
Now, when you apply kind of the chemistry and the physiology to this, when the liver and this is again still in the Chinese medicine world,
I'm listening.
when the liver gets stagnant or sluggish, it cannot metabolize the hormones well. They call that liver stasis.
Listen.
That liver stasis
Look at us.
leads to estrogen dominance. I don't know how you feel about that theory, which is a stored form of estrogen. Essentially, you're holding on to the metabolites of estrogen. You're not able to metabolize them effectively, which then in turn triggers the mutations that cause fibroids. That's the Chinese medicine interpretation of fibroids. So they have a lot of herbal formulas that would like target this, but then the Chinese medicine practitioner would be like, okay, take this herb, right? Follow this diet to help improve the health of the liver, to improve your fibroid. But please also let's work on your Shen or your anger to help release that to really bring about a healing response.
That is so fascinating to me. I have so many things I want to say. So first of all, I love this.
I know.
Because I can't.
Science with a little bit of woo. I love it.
That's me. I literally said in my book, I'm like a woo-woo girl with a scientific heart of gold.
Same.
So like, and
100%.
And don't you think we have to have more conversation?
That's the purpose of the show. That's the purpose of all of it. Yeah.
And also you ostracize people. And I'm like, wait, everybody actually wants the same thing.
Right.
Everybody wants
We're on the
health.
same team.
We're on the same team. Different ways to get there. And I think we can unite in that we don't want to cause harm. That's the main thing. So these are the things that come up when you say that. One is that I think that's fascinating.
Yeah.
Two, I always want to say, I want to be careful to say, I don't think this is women's fault.
No.
This is not me saying you're angry. If you were just less stressed, go meditate and these will go away. But it's actually recognizing that, can we be empathetic to like, it's not easy to be a woman in this society.
No.
It's not easy to be a woman of color in this society. And that has physiologic and biologic consequences. We already know from heart disease.
Right.
We know from hypertension. We can trace these things like from start to finish in some diseases, and we're working on the other ones. So I want to just make sure that people listening know that this isn't about blaming individuals, because I think sometimes that's the pushback. It's actually, to me, about saying it's blaming society. Like, this is part of the soup that we swim in. The second thing I want to say is about estrogen dominance a little bit. And this is where I'll push back a little bit, is just to say that we see fibroids develop, large ones, horrible ones, in women who have like never taken birth control. They've never taken any exogenous estrogen. And we see women with no fibroids ever who've been on birth control like every day of their life since they were 12. So I want to be careful about people thinking like me taking estrogen or estrogen equals fibroids.
Yeah.
Fibroids are actually, they grow from this very complex interplay between estrogen and progesterone. Estrogen kind of primes the fibroid to receive progesterone as a growth stimulant, is kind of how it works. So it's the two of them together.
Okay.
And it is true that when we've measured levels of estrogen and progesterone in women, they don't correlate to fibroid growth, size, or anything. So it's something, what that means is that it's not that those hormones don't matter, but it's actually about how the fibroid receptors are interacting with your hormone levels. So somebody who has really sensitive fibroid receptors might have super low estrogen and progesterone, and the fibroid is like, give it to me.
Exactly.
I'm growing.
Yep.
And somebody else has super high levels, and they might have one fibroid that has like one receptor, and it's like barely impacting it.
Do we have a test to test fibroid receptor sensitivity?
So this is what we have to work on, right?
Just
so
asking,
it's like, I know.
Asking for a friend.
I know, asking for a friend, right? But I say that not like, it's like all the yes and, which is that this is why we need these we need these systems so people can feel like, okay, what can I do?
Yeah.
And I start to say, like, I put in my book, one of my things is like, eliminate stress. Like,
Yeah.
we got to work on that. I'm not going to leave that off the list when I know that this is associated.
Right.
And then also there are some medications and there are some vitamins that we do know can halt and slow down fibroid growth.
Well,
And
let's
so
talk
like,
about those.
oh, okay, yeah,
Yeah.
vitamin D. Vitamin D is that girl, y'all.
Vitamin
Yes.
D is chronically low in a lot of
Yes.
my
Your
Black
patients
women.
and Black women, it's chronically low.
Why?
And the theory, and I will say that I'm kind of like, sometimes I get a little suspicious of this, and I'll tell you why. The theory is that, we have more melanated skin.
Right, so we don't
So we
absorb the
absorb
sun.
less. We
I
don't
never
absorb.
really bought that theory.
Thank you. Because first of all, like, so you telling me that all my ancestors have been
Right.
vitamin deficient for the last
Right.
thousands and thousands of years? Like, that
Right.
makes no sense to me. But
Yeah.
I acknowledge that's a theory. Dietary things can also, as you know, like
Right.
depending on like the quality of your diet and stuff, it can be low. So that's not my area of expertise. I'm not sure why it's low, but I know that the studies looking at vitamin D and fibroids do not, I mean, vitamin D does not shrink fibroids, but it halts growth. So it's I spoke to many gynecologists who only do fibroid care because I wanted to really get this right.
Yeah.
And they were saying, yes, like they tell all their patients, listen, while we're figuring out what to do, at least get your vitamin D levels up because we can slow things down. And we've seen that in studies. So that's really important. And any woman that has concerns about that, I would say get that vitamin D going. Another, when we think about actual fibroid growth, there's kind of two medications and the generic names are very long. I'm literally forgetting them right now. I feel really bad. Rigolix and something else.
Oh God,
anyway.
I forget that too.
I forget. Like,
Rigolix.
but they're combination.
Okay.
And they're actually a very specific targeted combination of a certain type of progestin that's kind of like more of an androgen, estrogen, and then another medication that kind of halts fibroid vascular growth. Like it stops them from growing the blood vessels that they need to keep growing. And those are both oral medications that do a very good job of halting and shrinking fibroid growth. So there are options that aren't just surgery.
Yeah.
But the issue is that when you show up and your fibroids are already 8-10 centimeters, or you already have 35 of them, that's where it gets difficult. And that's where, as a physician, I do say, like, we can do the teas. And we can do all these and we can do the supplements.
Right.
But at this stage, we're beyond, we're just beyond and it's like, what can we do to either like do a myomectomy or like bring things back and then start from there? Because once they're at a certain size, unfortunately, that original stem cell, you're not going to get to it. If you think about a stem cell in the middle, like you're not going to get to it
That's
anymore.
been my clinical experience. Like, patients come in all the time wanting a more holistic approach to managing fibroids.
Yeah.
And we are successful as long as those fibroids are under about 6.
That's right. 4 to 6 is what we usually say. 4 to 6 centimeters. Yeah.
But the minute you've got like, 10 centimeters, you have multiple. I had one patient describe her uterus to me as like literally an apple sack is what she described it as. I'm like, at that point,
it's too late.
It's like very difficult for these things to turn it around and for you to maintain the quality of life that I know you want to maintain. Yeah. So that's where this like middle road is so important, right?
It is. And that's why we need to work together.
Right.
Because it's like, and this is why I might get in trouble. This is why I'm not opposed to a woman at 22 being like, I would like an ultrasound just to see where I am.
Yes, why not?
Why not empower her?
Yeah, exactly.
Like, why not? It's something at least she knows about.
Well, that was going to be my next question. Like, if you're saying this is showing up as early as your late teens, why are we not doing routine ultrasounds on young girls after they turn about 16 or so?
I have two theories.
Okay.
So one is that doctors don't like to find things that we feel like we can't do anything about. And a lot of the, like, even the studies I just shared with you, like a lot of these things are, most of the treatments are developed for people who are symptomatic and severely symptomatic.
Right.
So
not preventative.
Right. And so I want to, especially things are different in internal medicine. I don't want to paint all physicians with one brush.
No.
But
We're
I
just
think
talking about the established
I think it's
standards.
fair to say in gynecology, we have not had a very strong focus on prevention outside of things like the HPV vaccine, which is great. And pap smears, like it's not like we don't do it at all. But when we think about endometriosis, fibroids and stuff, there has not been as much research and clinical focus on preventing those things.
Right.
We focus on treating severe disease. And so I think that's part of it too, is that just like as a physician culture, right? We don't like to find things we can't do anything about. And what I used to learn is that like, well, that doesn't like, there's no reason to find that because it's just going to make somebody anxious. There's nothing you can do, right? And it probably isn't going to bother them anyway. But as a Black woman, I have to say, I started to shift on that because I'm like, you know what? We say that, but then when they come in bothered, we don't believe them until they're severe.
Right.
And then once they're severe, we have one solution.
Right.
Take it out.
Right.
So there's something wrong with this narrative. And I am challenging us to say that's not quite the narrative. And it makes sense, especially that women of color feel so neglected.
Absolutely.
And it makes sense that they want to turn away to something else. And we can do better. So, yeah, I'm passionate about it. And then, well, we can keep going later, but I'll stop there. But yeah.
No, I mean, that's just interesting that you say that. And I guess I have the luxury of kind of setting up my own ecosystem when it comes to how we take care of patients and all that other stuff. But I'm actually challenged by the thing I don't know.
Me too.
You know what I mean? The thing I don't know has driven me for all these years. You know, it's what drove me into the journals when Black women were coming in, you know, with these sort of very similar patterns, you know. So the thing I don't know does not scare me. And maybe it's a problem with our education system that we've been sort of trained to fear that. But we should embrace the thing we don't know.
Yes.
Because it's going to lead to the next frontier, you know?
Yes. And also that's where the best ideas, scientific insights come from. Like, I think there's nothing better than biomedical science for a mechanism.
Right.
I think it's something so cool to be able to understand like something from like the DNA strand to the protein to the this to the that. I try to remind people that takes decades and decades and decades. So when you just start like last year, when we just started, it's going to take a while. However, I would offer that the ideas that drive what the question is often come from the outside.
Yes.
You know what I mean? It's
They
like,
always
it's a
do.
both and, yeah.
Right.
And so that we need to have more of an integrated approach, even when we think about research, because we'll get really interesting ideas to follow. And then we can see, okay, what does the science show? And sometimes we'll research something and we'll be like, oh, well, the science shows there's nothing there. And it's like, well, then I always go, okay, well then what is another way to ask the question? Or like, what was it about this group where everything, you know, we didn't see what we expected? Like there's always another interesting question.
Right.
And so, yes, I don't believe that we should do things that we know like don't work, you know, and it's like in both areas that we've kind of set up here that we're saying are integrated, but you know, we've set them up as like Western biomedical framework. And in both areas, I think the practitioners that have ethics and that really want things to go well, they're not interested in giving you things that don't work.
Right.
And however, there's a lot to be explored about how things work, why things work. The placebo effect, I'm sure you are very familiar with.
Oh, yeah.
I was always taught that as something like very denigrated, like,
Or
oh, that's
negative.
just placebo.
Right.
It's very negative. And I'm like, wait a minute. So by placebo, meaning like the person basically got better on their own because they believe they could.
That's enough.
That's huge.
That's enough.
And also,
You know,
if I can tap into the placebo effect, isn't that a good thing?
That's a good thing.
Isn't that I think that's an amazing thing. And how long has the tradition, in how many different cultures is the idea of laying hands on somebody healing? Is that not the placebo effect?
Right.
Is that not? So even that, I feel like for me, I identify as a scientist and I'm like, that is so interesting. And yes, of course, I'm interested in things that outperform the placebo effect, but I'm not going to denigrate it as a problem.
Well, the placebo effect is simply the body's capacity to self-heal.
Exactly.
And self-healing is really what all of our ancient, you know, medicine people, any culture, any tradition, any religion really advocated for, that it's within you. You know, go back to the Wizard of Oz. It's within you. You know, the answer's within you. So, I mean, I think, you know, we got really, really far away from that. We also don't want to recorrect.
We don't want to go all the way to the other side. Right.
But I think the physician community would serve everybody really well to be a guide in that. Right. To be a sound, trusted best friend guide. You know, which is different.
Here are all the tools.
Correct.
I think about it that way. It's like, listen, I tell people all the time, the biggest red flag for anybody that you go see is that they have all the answers.
Right.
That is, it's like, regardless of whatever the background training is, because the body is way too complicated for that.
Too individualized.
It's too individualized. There's like too much going on. However, like the green flag is somebody be able to tell you, listen, these are the tools that I have.
Yeah.
This is how I've seen them work. This is what that is based on. And this is why I think it's worth you trying it. And this is how we're going to reassess if it doesn't work.
Yeah.
Because that's the other piece is that, like, I think, again, in all different types of clinics, environments, people can get gaslit. Well, if it's not working, it's you.
Yeah.
It's like, okay, hold on.
Yeah.
The patient is the expert. And so in that sense, why would I be against anything that's working for somebody? So when I was practicing, I would say that all the time. I would say, first of all, let's talk about, I want you to know I'm curious about all the things you want to do. Like as a cancer doctor, most cancer patients are accessing some kind of alternative medicine in some way, especially if you define that as like acupuncture, everything, right?
Yeah.
So I'm like, I want to know. One is because I want to make sure nothing you're doing might be interacting with what we're giving you. And then two, if it works for you, I want to know that. If another patient asks me, like, what can I do? I can share with them, like, listen, I don't know if this will help you, but this helped this patient. A place that's open like that is a place where people feel empowered and where we give the best care.
I love that. And I hope that model is going to be there for the future. I know I'm trying to build it. And
I
so many people are
know.
trying to build it, moving forward so that people have more options, more choice, more dialogue, right?
More
And
dialogue.
we have to have a system of medicine that actually rewards dialogue at the end of the day. It'll
Yeah.
save so much money on the other end
That is
if you
so
could have
true.
these conversations
And they're rewarded.
in a relaxed
Oh
manner
my
and
gosh.
then make the
Not
right
time
set of
pressured.
choices, right? So,
Correct.
but going back to the crisis of the black womb,
Oh, yes.
I have two questions
Mhm.
there. One, I read a study not too long ago, you probably saw the same one, that talked about the chemicals in
Yes.
relaxers, some of the products in makeup.
Yes.
What's the story on that study? Is
Yeah.
that a link to maybe some of this?
Yeah, I think yeah, it certainly is. So let's take hair relaxers. So in hair relaxers, there's kind of like there's two different angles of concern about beauty products, we'll just
Right.
say broadly, and like the reproductive system. One angle of concern are the endocrine disrupting
Right.
chemicals. So things that might mimic in some way hormones or might be blocking hormone action in some way. And then the other category are just things that are like cellularly toxic or harmful. In the hair relaxer conversation, it is mostly the latter category. So it's mostly like things that are just like toxic in some way, shape, or form. And what we found looking specifically at women with regard to fibroids and with regard to uterine cancer,
Mm-hmm.
there is a link between the specific kinds of chemical hair relaxers that Black women are more likely to use because they're for very tightly curled and coiled hair.
Okay.
So they're very strong relaxers. I think that's very important. They're also more likely to cause burns on the scalp
Oh,
because
wow.
they're so strong, and so they're easy to seep in through the skin barrier. So the exposure level
It's
is
systemic.
higher.
Yeah.
Yes. So
Okay.
a very good study. This was actually done by the National Institute of Environmental Studies. Found that Black women who had relaxers 6 or more times a year, so they're going like every other month, they're doing their chemical hair relaxing, had a higher risk of uterine cancer. And it was very well done. This was like, and then there was another group that runs something called the Black Women's Health Study. I talk about this study a lot in the book because it's the only study we have with over 50,000 Black women.
Oh, wow. Okay.
Yes. And I recommend everybody go look it up because it's not talked about that much, but it's a huge study. They followed them for over 20 years and they collected a lot of information about fibroids, cycles, all this stuff. So the Black Women's Health Study went back to their data and they asked the same question and they found the same link. So there's clearly, it's about a 17% increased risk of uterine cancer with the use of hair relaxers in Black women, especially frequent use.
What's the dominant chemical in the hair relaxers?
I don't remember.
Okay. So is
Because they're all,
there...
because also, sorry, I didn't mean to interrupt
Yeah.
you.
Go
There
ahead.
are several different ones and I
Okay.
just can't remember, but there's a few that are like probably the most, like the agents of most concern.
Are there new products on the market that
Yes.
are a little bit gentler?
Yeah. So
Okay.
like, a Black woman, like a silk press,
Yeah.
like a keratin treatment, like these things are different.
Okay.
And they're used, and also a lot of women do, they end up with what we call mechanical straightening, right? So
Right.
like, and it kind of gives you the same look. There's no concern with that.
Okay.
So we're really talking about classic chemical, no lie relaxers. That's what we're really talking about.
Got it.
And so I tend to say, I feel comfortable now saying, recommending Black women avoid those. It doesn't mean you can't straighten your hair, but
Right.
just don't do it that
That
way.
way.
That way.
Gotcha.
Yes.
Okay. And then the other question I had, just more of a curiosity for
Mhm.
me, A lot of my patients will go get
Yeah,
myomectomies, but then they're right back in the
yeah,
same spot.
yeah.
What's happening there?
Yeah, so with myomectomies, thank you for asking this question. So it's when you have myomectomies are most successful. About half of people who have a myomectomy will have their fibroid grow back. So I try to make people clear about that because I'm like, so that's half that don't, and then half do. So
Mhm.
how can we know which half you're going to be in? There are a few ways. One is myomectomies are most successful when you have one dominant fibroid.
Mm.
So it's like it's one fibroid, it's 6, 7, 8, 9, 10 centimeters. You don't have a uterus riddled with fibroids. So that's more successful. When you have multiple fibroids, multiple large and small fibroids, it's much more likely they're going to grow back because remember why
Mutation.
fibroids grow, one single stem cell.
Mm.
So when you have like 10 fibroids, you're removing every single one of those stem cells, those individual different mutations that created each one of those fibroids. It's a lot less likely that's going to happen. It's a lot more likely that you have small fibroids that aren't actually removed, and so you haven't removed all of the stem cells. Does that make
Interesting.
sense? So that's
Yes.
a big reason why it
That's an
grows
important
back.
differentiation
Yes,
too.
and
Yeah.
why it's not unreasonable to pursue a myomectomy potentially if you have one dominant fibroid that is not responding to medical treatment, because you're
Gotcha.
actually in the group that's most likely to succeed with
Hmm.
the surgery, right? So one of the issues with that regrowth, and I get why women would choose it. I understand,
Yeah, yeah.
is that we have women that are doing myomectomies with lots of fibroids, and the success rate is going to be lower. The second, um, the second issue around myomectomy is what happens afterwards.
Right.
So what we also want is if your fibroids are going to grow back, we would at least like to give you several years. You know what I mean? Like we want it to be like 10 years. We want it to be a long time before you have to deal with it again. So what's happening in that intervening time? Are those things that we talked about happening? Are we getting vitamin D
Mm.
supplementation?
Mm-hmm.
Are we on preventatively on the medications that I said actually shrink
Shrink it.
fibroids? So it's like, hey, listen, just in case, you know what I'm saying? There was a 1 centimeter fibroid we didn't find or a stem cell left behind. Let's do some preventative treatment. So are we on things that we think are going to prolong that time? Or is it we took the fibroids out, fingers crossed?
Mm. Is there not any, with all the work on stem cells right now, is there not any evolving therapies with stem cells
In
to
progress. I mean,
in
they're working on it.
progress?
They're
Okay.
working on it. We now have in the last 5 years, the NIH just in the last 5 years actually funded large centers of fibroid excellence in research. It's like a
Mm-hmm.
specific kind of NIH center where
Right.
you
I think
get,
I saw that.
yeah,
Yeah.
okay,
Yeah.
you get
Mm.
like molecular biologists, geneticists, like you get every
Right.
kind of
Person.
discipline all working on the same problem.
Mm.
So we've got a few of those now. Right. So it's going to take
Take
time. I
time.
know, y'all, but we
All
are going to
right.
get there. So it's
Okay.
frustrating because we're behind, but I never want the narrative to be like, we don't care. There's no research. Like nobody, like it's not true. We're not doing anything, but it does take
Time. What
time.
about PRP? Have you seen those uterine washes with PRP? I'm just curious. I'm just asking. I'm just curious.
Okay. Did you see the recent, oh, wait, okay. I just saw this about the plasma. It was a negative study and I just cannot remember what it was about. Oh, that's bothering me. It was for, pelvic floor, that's what it was for.
Okay.
It was for, pelvic floor issues, like a urogynecology issues, and people doing PRP for urinary incontinence and weakness
Mm.
in the pelvic floor.
Okay.
It did not
Do
work. It
anything?
did not help,
Okay.
no. So I really don't like it,
Okay.
and I'll explain why.
Okay. And
Is
maybe
the
explain what PRP is too, just in case someone listening
It's
is
the
not a yeah.
plasma-rich,
Yeah.
I forgot what the third piece stands for.
Platelet.
Plasma-rich platelet
Right.
infusion. Okay. So here's a few reasons why I don't like it. One is that the endometrium, so that's the inner lining of the womb, is a very tightly controlled space. It's one of the most protected spaces in the body, actually, right? Because to grow a life, it has to be like immunologically protected. So there's a lot of that's actually why it's difficult to develop treatments because the uterus
Mm-hmm.
is like, don't come in.
Right.
Right? Like
Right.
you are not allowed in
Yeah.
here. Okay. So menstruation, going back to the wound with the Scarless repair, is this very tightly regulated system of the hormones and then the inflammatory system, which includes platelets, right? Macrophages, prostaglandins that all come in and they grow these spiral arteries. This is actually really beautiful architecture. And then those arteries unwind. And it's this very tightly regulated system. I do not like the idea of inserting more platelets, plasma-rich platelets, into that system for growth reasons
Mhm.
when actually growth factors are never a problem in the uterus. That's not the problem that we have. It's not
Interesting.
an area where it's like, "Oh gosh, we just, like, need more." We don't ever need more of that.
Yeah.
Most of our conditions come from too much of that. So it's like, I just again, this is not my scientific opinion from the mechanisms, but this is my scientifically informed perspective that when I think about PRP, I think about like aging. I think
Right.
about, like
Right.
places where you're
Yeah.
trying to like get more, and that's not the condition of the uterus. So I
Interesting.
don't like it.
You don't like it. All right. So no to that. All right. What I'd love to do, I'm thinking about my patients. I'm thinking
Yeah.
about our listeners and viewers, and they're hearing this conversation
Yeah.
around the womb,
Yeah.
around fibroids, and they're like, well, what do I do?
Yeah.
So can we just go down the arc of being a woman? If you're
Mhm.
a teenager, if
Mhm.
you are a young Black female teenager,
Mhm.
what would you have them do?
Oh my gosh. Okay. So a few things. One is I would have you establish care with a gynecologist that you trust, that you really like. I promise you they exist. There are, especially we have this whole huge crop of new generation,
Yeah.
holistic
Yeah.
minded gynecologists. I say that because you should have a gynecologist before there's a problem. A lot of times, and I am completely part of this problem and I'm
Yeah.
working on it. We only go when there's a problem, but now that person does not know you're normal.
Right.
That person is starting from
So know your
scratch.
normal.
Yes, so you need to know you're normal, and then you need a doctor to know you're normal. I encourage everybody to do a 3-month symptom journal.
Mm.
It doesn't take that much time. It's like just a quick everyday bleeding, cramping, anything going on down there. You will now know this is what is normal for me. First of all, what you write down might surprise you. You might be like, actually, I bleed and cramp a lot.
Mm.
And that's a sign to go in. Secondly, you now have a record of normal. And Dr. Taz, you know how physicians are.
Yeah.
It's totally different to say, like, I think something's been a little different for a little while than to come in and say,
Look at
from
this.
January to March,
Right.
this is
Right.
what it was.
Right.
And then because it
Right.
already starts us, we already start going, okay, it could be
Right.
this. Like,
Right.
it turns on our
Instantly.
differential
Yeah.
diagnosis.
Yeah.
So I tell people, speak that language. So do a symptom journal to know you're normal. If everything's fine, put it away. Now you have it. If it's not, you are already collecting data for that future appointment. Get a gynecologist so that you have somebody who knows you and
Mhm.
you don't have to convince them when something has changed because they already know your baseline.
Okay.
Number 3, in terms of womb health, know your family history. Does endometriosis run in your family? Do fibroids run in your family? What are periods like in your family? We don't have these conversations often. We need to. Get a blood count and an iron level. 30% of Black women with heavy periods are anemic.
Mm.
30% are walking around without enough oxygen in their blood as a norm.
Wow.
Get those labs tested. And then you said young Black women.
Mhm.
Oh my gosh, healthy, encouraging, positive relationships in your life. It is
Love
not
that.
too young to demand
Yeah.
a high standard for people who interact with you, for your romantic partners, for your friends. Like, I love that people are like reclaiming themselves, but aren't you tired of the reclamation happening at 45?
Right.
How about 25?
I love that.
You know what I mean?
Yeah.
And lastly, I talk a lot in the book about womb sisters, which is that we've got to break the silence and say we need a sisterhood where we can talk about these things for real, for real.
Yeah.
I understand what it means to ask Black women, especially to go to the doctor when they've had such negative experiences, and I don't ask them to go alone. You don't need everybody in your friend group to know your business, but
Right.
you should have one friend
Who's an
that
advocate.
who's an advocate that doesn't care about all the details, that can be an objective ear for you, and in a very vulnerable exam and environment, be an anchor.
That's a really great tip, actually. I love that. Let's move on to the woman now entering her 30s
Yeah.
and going maybe into her childbearing years, coming
Yes.
right out of it. What would you tell her?
Yeah, so I would tell her that it is really easy in your childbearing years, after you have kids, you're chasing your career, all those things, it is really easy to literally disassociate
Yep.
from what's going on down there, right? You just like, I don't exist below the belly
Right.
button.
I only
right? Like,
exist here.
I am right here.
Right up here.
Right. And you're going, because I do the same thing.
Yep.
Go, 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 go. It's
Yep.
very, very easy to disassociate. And that is actually where we see the most severity of symptoms during that time that are
Interesting.
untreated. It is
Okay.
in the 30s. It's like everybody is just go, go, go. They're taking care of their kids. They're taking care of their parents, all this stuff. And especially for Black women, like this is the time when we could actually intervene.
Mm.
And often, you know, if you look at the hysterectomy rate, it's like low in the 20s. There's a little blip in the 30s. And then you look at Black women and it's just like skyrockets. Because
Wow.
that's when women, you know, their kids graduate, everybody moves out, and they're finally like, okay, let me take care of myself.
Yeah.
And now there are no options.
Right.
So this is the time where we have to make a specific point to say, I have to prioritize my womb even when it is inconvenient to other people.
Mm.
If something has changed during this time, I have to put something aside in order to take care of this for myself. And also I start thinking about screening for cancers, right? So we start thinking about, oh, I should tell the young people to take the HPV vaccine.
Yes.
Sorry. HPV
Youngsters.
vaccine.
Yeah.
Please.
Yeah.
Okay. So this is when you start thinking about, 7% of uterine cancers happen under 45. So we start thinking about talking to your doctor about your risk factors for uterine cancer. You start thinking about optimizing your heart health, because almost everything that you do that helps your heart helps your womb. That's another thing I tell people. Anything you hear about heart health helps your womb. It's when we start thinking we have to be a little bit more careful about dietary things. We have to start being careful about high processed sugars and high what do you call it? You know this better than me, Dr. Taz, the high glycemic index.
Oh, yeah.
Foods
Inflammation.
and diets and
all of-
inflammation
right.
that drives fibroid growth. It worsens endometriosis. We know that for a
Right.
fact.
Right.
So you have to start paying a lot more attention to that. And then also I have to say alcohol. Alcohol increases fibroid growth, y'all. I'm sorry. I'm telling you the
It's
truth.
the truth.
So I think the 30s are a time where there is a deliberate effort to carve out a piece and say, what am I doing to make sure that my womb and the rest of my body health is as optimal as it can be, even if it's inconvenient. Now we get into, sorry, go ahead.
Well, no, I was going to say, now we move into
40s, 50s.
and 50s.
Okay.
I'd love to
Perimenopause
hear
years.
Perimenopause and menopause.
Yes.
And I have a visual of a couple of women who've come, lots of fibroids,
Yes.
kind of an angry uterus, asking
Yeah.
me if they can save their uterus.
Yeah.
What would you tell these women?
I would say maybe, maybe not. And I would say, and I would be really honest. And I tell a story in the book of like honestly having to tell a woman in her early 40s. She was actually she had just turned 40. And I
Some
had
of
to
them
tell her,
haven't
"You
had
need a
children
hysterec-"
yet.
Oh yeah, she had not
Yeah.
had children.
Yeah.
I said, you need a hysterectomy.
Yeah.
And so I'm honest about that because I don't want you to live a life of anemia, of pain, of cramping. At year 40, I assume you've got 50 more years, girl.
Right.
So
Good
we are not
point.
going to suffer through that.
Yeah.
So if we haven't done that prioritization in our 30s, right? And you're just coming in, it is seeing a holistic doctor, a specialized gynecologist, so that you can walk through all your options and your fertility options. So surrogacy might be an option for you. Harvesting eggs might be an option for you. All of these things. 2, it's recognizing that you are about to enter the menopausal years. And it's probably going to be very helpful for you to get an assessment of whether menopause hormone therapy is going to be helpful for you and protection for your womb during that time for everybody. Because there's women who are listening who are like, well, I haven't really suffered from fibroids, endometriosis, anything.
True.
You're still at risk for uterine cancer, especially if you're on estrogen only therapy.
Right.
So I think I talk about that a lot. And then making sure that you stay in care during menopause, because especially for women of color, what can happen is a lifetime of fibroids, a lifetime of heavy bleeding means that as they go through menopause, Dr. Taz, they actually don't have that 12-month without bleeding because they're symptomatic from other things, and it can mask uterine cancer bleeding. So you need to be in routine care with somebody who's watching that pattern, because your periods should always be getting farther apart and lighter, farther apart and lighter, farther apart and lighter. But what happens, especially with Black women, is that that starts, but then maybe they start bleeding more and they start bleeding more, but it's all just perimenopause,
Right,
and we miss those signs.
Miss the big things.
Yeah,
Right.
and so
Interesting.
staying in care is really important. And then post-menopause is just making sure you still get that annual exam because, you know, there are vulvar, vaginal cancers, other things that can happen that are more common 60s, 70s, 80s.
So a lot of women aren't going after 60.
I know.
But you want them to go.
Yes. I
Okay.
want you to go. Sorry.
No,
I want you to go because it
Yeah.
goes back to what we talked
Yeah.
about. Are we just childbear? I mean, are we just here
Right.
to childbear?
Right.
So vulvar and vaginal cancers are most common in women in their late 60s, early 70s. And you know what would happen? We would see women with literally masses on their vulva, on their vagina that nobody had bothered with, women in nursing homes or not, women who otherwise looking great, because the thought was, oh, I might have a UTI or maybe I have like an STD or something. There's nothing nothing
Right.
to really worry about down
Right.
there. And as gynecologists, it's so frustrating
I'm
because it's like,
sure.
why these organs still exist? Why do we have this paradigm where we just act like they're not there anymore?
Right.
Like, is there any point where somebody goes like, oh, we don't worry about your heart anymore? Is there any point where we're like,
Good point.
kidneys,
Your bones don't
you're
matter.
old. Yeah, your bones don't matter. You know what I'm saying? Like,
God.
even your teeth, like it's
Yeah.
like the uterus is the only organ, misogyny,
Right.
where it's like, oh, you're not producing babies? Probably fine. Don't worry about it.
Yeah.
What? Like, what? How did this happen?
You said it. Misogyny.
So,
Well,
yes.
your book is out.
It is.
Talk to us about the book. What
Oh
can
my
we find in
gosh.
there? What do you want people to walk away with?
I want people to walk away so informed that they never feel intimidated by going to seek women's health care again. I want them to feel informed so they can look towards any type of practitioner they want to and feel like they can understand what that person is saying through the lens of the biology. I promise you it's not too scientific. I promise you can follow it. And there are incredible stories in this book of women not just enduring womb suffering, but overcoming it, including my own story of my own journey to endometriosis and my own journey with fibroids. And ultimately, it is an empowering book. You're going to want to give it to your friends. You're going to want to take it to your doctor. The entire third part of the book is just how we can heal. And as we talked about, through many ways. So I want to bring these worlds together. And it's why I include information about vitamins, supplements,
Amazing.
emotional management,
Love
and
it.
medicine
I
and
love it
surgery.
so
It's like,
much.
because
Yeah.
that's the world we live in. So please pick it up wherever you find books. Give it to your mother for Mother's Day. I don't know
Mother's
if
Day's right
you're
around the
late
corner.
or early,
That's
you know what I'm
right.
saying? And I think it will definitely serve you.
Well, I am so honored to have you here. We have a crisis when it comes to Black women's health. We both know that.
Yeah.
I've sat with so many women, both in our clinics and then prior to my clinic life, I was in the ER.
Yes.
So, got to witness firsthand kind of some of our breaks and how women are not served well. So I'm going to encourage everybody watching and listening to please share this episode with at least 2 to 3 other women in your life. And I don't care if they are 12, 13, 14, or they're 70, 75, or 80. I feel like we have to get this message out there. So please share it. Let's get educated. We can take care of the body. The body's incredible. We're both fascinated by it. But if you don't know, then you don't know what to do.
Yeah.
And Dr. Kemi, thank you so much. I love this episode.
Thank you.
Well, before I let you go
Okay.
and unleash you to the world, what makes you whole?
Oh, that makes me. I can say more than one thing.
You can say more than
What
one
makes
thing.
me whole is remembering that I come from amazing people and that my life is like a blessing to be able to live this life. I'm literally grateful. I'm like grateful to God, the divine, for trusting me to like be alive. What makes me whole are my kids. They're so
Yes,
sweet. They're
yes,
7 and 11
family,
and like they are adorable. I love my husband still, so that's always
That's always
great. We have a
good.
good time. And really just feeling, it's like we talked about this before we started recording. There's nothing like feeling like your work has meaning beyond you.
Yeah.
I am so renewed by that. So
And
yeah.
We're changing generations. So
Thank
that's
you.
huge. So thank you again for joining us. For everybody else, please remember another little plug to, first of all, get the book. Secondly, share it. I go deeper on all these topics, including fibroids, women's health, Black women's health, and more in my private community, The Circle. So if you've not joined yet, now is the chance. Just go to wholeplus.co/circle, and we will see you next time. Before you go, remember healing doesn't happen all at once. It happens in moments. If today's episode gave you one of those moments, subscribe and keep learning with me. The next video is right here, and it picks up right where this one left off.